Okay. Shaq, let's gather the troops. So before I present our next speaker, some housekeeping stuff because I know toward the end. Ah, okay. So I want to do some housekeeping stuff again. One, they will have two speakers right now, and they will have case presentations. After that, we're going to conclude the meeting, and we're going to have a training from Livanova on the Tandem Life. That will be outside the meeting, next door. The duration of the training is going to be around 90 minutes, and you'll be certified for Tandem Life. So this is number one. Number two, again, please don't forget the QR code for the evaluation in order to get your CME. Number three, uh, please, we need your feedback because we're planning on doing this again next year. I want to figure out under what format. Do you want 1 day or 2 days? We're going to try to get more speakers and different topics. So we need your feedback about the topics, the format. What did you like? What you didn't like? All kind of feedback that you can give it to us either via the evaluation form, or you can email me or email Dr. Shakur, because this meeting is for you guys, for our physicians, for our nurses, for our healthcare, other healthcare providers. So the next talk is going to be by Dr. Ram Kalia. Again, he comes to us from Banner. He's the director of cardiac rehab and the heart failure center, and he's going to present to us some cases to illustrate everything that we talked about over the last 2 days. And next will be Dr. Roach.
Thank you, Dr. Nasir. So I'm hoping that I can tie everything that we talked about in 2 days and just by 2 case presentation. You know how varied some of these cardiogenic shock patients are. So I'm going to try my best to see, just to illustrate some of the things that you normally do as opposed to trying to tell too much about VA ECMO. I think we've heard a lot about it. So these are real cases, by the way, and this is exactly what we did. So I'm not making up any of these things. 48-year-old female who we've known for quite a while, actually. It's just my voice, it's so echoing. Who's known to have non-ischemic cardiomyopathy, fairly compliant. We followed almost for a couple of years, was fair doses of guideline therapy for heart failure. In the about 6 months prior to the presentation, she's had some progressive decline in function and status. We started seeing her more frequently in the heart failure clinic. At one point, her blood pressures were kind of lower, so we started lowering some of the medications just to accommodate. So her blood pressures were running in the 88/60 in the clinic, and she was a little more fatigued, so we dropped down the Entresto, the usual things that you guys do. What's number one thing you worry about when you start lowering the blood pressure medicines? Patient is hypertension, yes, you lower the blood pressure, then what's the underlying thing that you're worried about when you start lowering? Kidneys. That means the patient is getting sicker. That's the number one thing. So anytime you start lowering, who is actually tolerating 49, 97 Entresto, and having all these things, beta blocker 25, then you start lowering the medicine. It means there's something going on in there that medicines alone is not going to cut it. So at that point, you want to really start looking further. That's basically what we did. We do periodically do right heart caths on some of our patients. And if they're really solid, never been readmitted to the hospital, 6 months, 1 year, 2 years, there's no reason to keep doing right heart caths or any of those things. A lot of times these patients' history are so dubious, right? So they tell you, yeah, I'm doing okay. And you just say, hey, how are you? I'm doing fine. So we don't know what that means. And she doesn't know what that means either. So we really don't spend the time to really say, how much do you walk now? And you were saying you were bicycling for 30 minutes. Are you still doing it? We don't have time for that. So anyway, including me. It's so important if you spend that time, you really understand exactly how these patients are doing, because that becomes important, because that's how they crash and burn when they come to the hospital or they have an acute MI or acute on chronic heart failure issues. This has been brewing for a little while that unfortunately, we're not able to recognize too well. So that's the main thing. So we do periodically do right heart caths on some of these patients we come in. This was 8 months prior to her admission index. So we did a left heart cath too, that was okay. Right atrial pressure was 16. So it was already you start seeing here, PA saturation 56%. Index was kind of hovering around, as you know, 2.2 or less is actually cardiogenic shock for definition purposes. So 3.3 Wood units of PVR, heart rate was 92, blood pressure was okay. And then now this is the current time, and we've already lowered her blood pressure reading. She comes in, and we put her on milrinone at that time, okay? She goes home on milrinone at this time because the index was low, she was feeling bad, and she has been on an inotrope for a little while. So how many patients follow patients on inotrope as outpatient? Okay, perfect. So that becomes important. So when we put any patient on an inotrope, it's a double-edged sword. I know it kind of helps, but at the same time, it can truly deteriorate some of their underlying heart failure milieu. So we see those patients every 1 to 2 weeks, actually, very closely with the nurse practitioner, and et cetera. So we do that all the time. So she comes in, and this is actually after being milrinone. We diuresed her because we felt like she was extremely volume overloaded. And actually, she diuresed really well. Right atrial pressure, look at that, 2. Look at the wedge pressure of 12. So we did a great job here. We could come back here and look at it. 46% PA saturation is much lower than before. So then truly on inotrope, she was really dwindling down with a really low cardiac output and cardiac index. So that was one of the concerns. So the patient was not making up anything here. So she was really telling, I can't really do this. So you could ask me what the renal function got a little worse when we did that, and the PVR is slightly elevated. So we're concerned about a lot of things here. What is her right heart doing here? Is that working? So what do you think about the right heart just looking at these numbers? Not giving you a PAPI and all this confusing things.
High, actually, that's significantly high, which is the opposite of what you expect with milrinone. You normally expect milrinone to drop the PVR, but it's actually going the other way. So I think the RV function is going down.
Okay. What else could be happening that could actually increase your pulmonary vascular resistance? On the left side. So her LV, let me tell you, 6.9 centimeter.
VP are going higher and LV dysfunction. So this the right side is probably related to the left side failure.
Some MR, but no, remodeling PA pressures are down.
So all it tells you the PVR being high is remodeling of the pulmonary vessels. The question, you have to figure out why. So is it truly RV failure? Will that cause remodeling of the pulmonary arterial circuit? Or is something on the left side that could be also remodeling, right? That could be MR. So if your long-standing MR can, over time, create thickening of the pulmonary arterial vasculature and the tunica muscularis, et cetera, can increase your pulmonary vascular resistance to a certain extent. But we want to see that if this is...
Should we not see, if it was pure MR, should we not see more
big wave,
higher PA pressures?
So,
some V wave or something like that?
Good point. So, we diuresed the heck out of her. So look at the wedge pressure here. So you're right. This may not be a severe MR at this point, dynamic MR. This may not be very severe, just given her, you cannot reduce your LVEDP down to like 12 or single digits. If you severely have an MR wide open, it's going to be really hard. You're going to see peak P waves, et cetera. So, do you...
And by insurance, because their URA and all that stuff are not up to par, but they're next for medical therapy. So,
it's sometimes hard. It's sometimes hard. But untreated MR for a little while may result in some. And a lot of times you could reverse some of these things too. So it's not terribly high PVR that they truly have another diagnosis on top of this. That's something to keep in mind. So you think the cardiac index is low, right? Definitely low, okay. Yeah, okay. PSAT, yeah. Yeah. So she's definitely not perfusing, oxygenating her tissues well with that kind of a saturation.
Yeah,
What's the other question you want?
With the same blood pressure, almost the heart rate is 10 points higher, and PA saturation is lower. So overall, she's coming across as a low perfusion state.
Always think about anemia. Don't ever shortchange anemia. You'll be surprised. Because now it's shown that the mortality improves. Patient is truly iron deficient anemia. You replace iron replacement. It really helps these patients. Always think about anemia as a part of that. So that's important. Okay, we'll go to the next step. So we did a whole panel on that particular right heart cath right there. Sodium is 128, BUN is 45, creatinine 1.9 to 2.2, kind of ranging in that. Sorry, my spelling, creatinine. Lactate is 1.9. LVF on the echocardiogram, 15% RV, moderately dilated, moderate dysfunction, mild to moderate MR, LVEDD is 6.6 centimeter, moderate TR. She's more fatigue reported. Of all guidelines that we took about everything, which is never a good sign, never a good sign. That's why they say, Doc, you put me on all these medicine, I feel horrible. I don't know why you put me on. You hear that all the time. You're right, exactly right. So when you put them off all that with that kind of hemodynamic, you really have to be concerned about this patient. So this is just, this is the C, B and C of your sky. So right there, hopping back and forth. So you just have to be careful. Limited participation. So we always try and get these patients, as you heard in the prior talk, Dr. Lamont talking about how cachectic these patients are. Which is the least thing we pay attention to is activities. We just put them in this hospital, in the bed. And they probably walk around a little more when they're at the house. But here we serve them everything, including the potty stand by the bed, right? I mean, they don't move. It's the worst place to be is the hospital, worst place. They get worsening cachexia. They don't move around, and they leave the hospital. That's why they all need physical therapy because they're so bedbound. So it's so important. So we always try and pay attention to physical therapy. We always engage physical therapy right off the bat. So they tend to move at least the patient a few minutes out of the day. And we also encourage the nurses to really help these patients out. So limited participation PT, but still able to walk a little bit back and forth to the bathroom. Okay, this is your decision process. Now you have to help me see what we can do with this patient. So what can we do? The next best step. Increase diuresis as the patient remains short of breath. Increase milrinone to 0.5 micrograms per kilogram per minute for better afterload and inotropy. Add dobutamine 5 mics. Why don't we just add that because index is low. Impella placement. We just put an Impella in. LVDP's DDD is high, 6.7 or 6.6. How about an IABP placement to improve diastolic augmentations? She's not ischemic. Why don't we just refer her for an LVAD or a heart transplantation? You can't pick 6. That's always right. I'm just kidding.
The last option is the best option. It's not working on it.
Yeah.
So they're Intermax 2 sliding on intros, right? So
That's right.
these advanced options, if they're available, will be your only next step.
Yeah. Consensus?
She's still walking, so it's not
Still walking?
So it's not that you need any devices to be placed because
Yeah.
she's still walking.
Okay.
So
What do you want to do?
Three.
What do you?
Only 3. I'll take 3.
You want to add dobutamine?
No.
Touch.
Little touch, and then what next?
Yeah,
Dr. Lamont was saying about you add these little things in there,
Well,
little
you have
touch.
to try, right?
You have to try.
Yeah. You
Sure,
can't-
yeah, you're right.
The wedge is not elevated, so using dobutamine, I don't know how much extra, even diuresis, it may not be very helpful unless you have a like perfusion
Right.
kind of like Lasix pump or something
That's
like
right.
that. But I think the only option is really 6 right now.
Okay.
He said
I
she
mean-
was anemic, but there was no hemoglobin.
Okay, I didn't tell you. So she's not anemic.
She's not.
Right now.
So,
Yeah.
we're talking about MR, so you want something to decrease the afterload. Your
LVDP was
options-
what now? You remember the LVDP?
What was it?
What was the wedge pressure?
12.
12.
So I'm not gonna achieve a lot with that.
Yeah.
Right. So just looking at those previous numbers, right? Your afterload seems to be better well managed. So there is no need to reduce the afterload either by devices or by medications.
Go back to the numbers.
Yeah. So your wedge is 12. Your CVP is 2. Mean RA is 2. So she's very well decongested or diuresed. So you don't need afterload reduction. You don't need preload reduction. The contractility, the index has gone down. So you need contractility. But adding dobutamine, that sounds like a reasonable option, but it's going to increase the heart rate. Already she's 103, which probably is going to be counterproductive. So I think 6 is.
For you, Ram, that
Yes,
you can
sir.
use now. You can add Farxiga.
Farxiga, there
While
you
you're
go.
waiting for 6.
That's it.
Why not Jardiance?
That's it.
Either way, I mean, like, one
Oh,
of
they're
those.
sponsored by
Yes,
Jardiance.
Jardiance.
Whatever,
Yeah,
like,
Jardiance.
We just left the patient on Farxiga. Just,
No, I'm saying while you're working it up to 6, LVAD and stuff, that's the one thing that you can do. It's not gonna affect the hemodynamics. It'll cause some diuresis.
Sodium is low too, and some salt.
Obviously, this patient is just one step away from being dry and cold. What about adrenal insufficiency? At any point, do you consider working on for it?
We definitely do. I mean, not off the bat right away, but if the patient is in the ICU we always do a co-centropin stem test and all those things. We definitely do that. But, likelihood is not because she's just a pretty, 24, 48 hours sort of duration is where we have she's been in the hospital. Yeah, that's a great point. Yeah, she's cold, and so that's exactly the profile I was looking at. What'd you say it was?
Cold and dry.
Cold and dry, so, yeah, you can't do much with cold and dry. You can't do it. So it's truly low cardiac output, truly low cardiac output. She's not filling up, it's just a matter of her cascading down. So this is one patient you have to be extremely careful because these are the dangerous patients. And you remember, you've kind of followed these patients, you know how these patients have performed well in the last few months. But sometimes when you get an acute patient, you don't know anything about the patient, it's going to be hard. But we have followed these patients for a while, so we kind of know, this is an acute situation for her. So, those are all.
ICD, does she have a 5V pacing?
Yeah, I didn't tell you those things. She had a narrow PRS complex. She doesn't have a BIV. She does have an ICD in place, yes. Yeah, so so this is what we did. So those are valid. So diuresis, like you brought up, right? There's nothing more to diuresis. It's pretty dry as to see that. Milrinone, you can increase it up to, but afterload is not terribly bad. Even though its SVR is still a little high if you do the calculations on that one. Dobutamine of 5, once you start adding a second inotrope, you just have to be careful with these patients. The likelihood of her going into arrhythmias is exceedingly high. Then you caught up with either AFib, RVR, you caught up with VT, then we have to keep calling you, and then you put them on amiodarone. It's just one after the other keeps going on, so you have to be extremely careful when you start adding a second inotrope on these patients. So this is what we did. So IABP was actually chosen. So there's a couple of things. So you're right. Putting in an Impella is absolutely, so we always pick an axillary route for these patients. So we kind of know that this is going to be something that we may have to keep for a longer time until we decide what we need to do. And we did look her for LVAD and transplantation. That was obviously the choice we wanted to do. But to segue her to an LVAD or a transplant, of course, transplants are going to be a long stretched out. She's been worked on for transplant, by the way. As soon as we put somebody on an inotrope, we're absolutely looking for either a durable device or a transplant automatically, or a palliative care. 1, 2, 3. Palliative care, durable device, or transplant. So it's automatic. So we don't just put him on and just follow because it's just a matter of dying in a few months. So we decided a balloon pump because of the couple of reasons. So her LVDP was not terribly high. It's great if she really had severe moderate MR, LV 7.2 centimeters, wedge pressure is 25, 28, 30. That's a great patient, and you've diuresed her, kidneys getting worse, sodium is falling, Impella, no question about it. Blood pressures are low. That's another thing that I would pick Impella. Blood pressure is running 70s and 70s over 50s. LVD is hardly moving. You have very low pulse pressures. LV is huge. MR, right side is affected. Put in an Impella. A lot of times they will really sort out, is the RV going to come back or not? Because 80% of the times when the LV is so dilated, you put in an Impella 5.5 is definitely preferable if you can get that. just do that, especially if you think it's going to be a long run situation. At least put in a CP. So hopefully, once you unload the LV, the RV majority of the times come back to normal. Majority of the time, surprisingly. So in her situation, why we didn't take her to a big Impella was one, the LVDP was so low, CVP was good. RV was, even though it was moderately dysfunctional, was still okay. We've never seen an RV failure with a CVP of 2. Very, very, unless they have tight, I mean, even if you have some other issues, like for example, pulmonary arterial hypertension, CVP might be a little low with the RV being dilated. But surprisingly, with her milieu, we've rarely seen a patient with a very low CVP with RV failure, very rarely. Unless the RV is so underfilled, that's a different story. So we decided to do an IABP. The filling pressure is not improving how much cardiac output the IABP is going to provide. You already had that. Not much. So 0.5, maximum 1 we've already seen. That's that far out. But a lot of times, just, when we talked about systemic vascular resistance being high, a lot of the times just having that afterload reduction with reduction of the L, doesn't need, but just that itself is going to improve your peripheral circulation to the greatest extent. Actually, patients do a lot better, surprisingly. So it's not really augmentation in some of these patients. Just providing that afterload and some peripheral vasodilation is more than enough for these patients to do well. And remember, these patients are living in this situation for months to years. All of a sudden, we do this right heart cath, we see this number, and say, oh my God, we got to do something. Because we know the CPO is low, PAPI is high, we got to put in an Impella, It doesn't have to, because these are well-compensated patients, except for the ones that you see. In acute MI, you bring it in, they're not compensated. You may have to do something more aggressive. But these are well compensated. Sometimes a very benign thing, it's not really benign, but compared to other devices, very benign thing. Put in a balloon pump, you'll be surprised how well a good augmentation is. So
putting a balloon pump increase her level on the transplant list?
she will go up to 2, inotrope and balloon pump.
She's already on 2, right?
On board, she's already on 2, right?
4.
She's on 4.
4. But we put her on the transplant list. Her biggest challenge I'm going to show you is, she had what we call, I think you heard in the previous, panel reactive antibodies. So PRA was 99%. She had 4 kids, which is the basic. Did Dr. Lamont cover that at all, panel reactive? So what general population has, so if you are a multi-parous woman, you've had blood transfusions in the past, you develop these antibodies within the system called HLA antibodies. So your body is making these antibodies against whatever, it could be a pregnancy, multi-pregnancy, et cetera, or blood transfusion, that is so high that you transplant these patients, even with the most aggressive immunosuppression therapy, they reject. And it's so hard to drive those panel reactive antibodies down to the extent. So you go around trying to match this particular patient to get a heart, you'll never get it. So either she waits, obviously not on a balloon pump, so either that or go towards something else more durable. So that was one of the reasons. So within 48 hours, surprisingly, I mean, not so really surprisingly, mixed venous improved to 62%. We did an axillary balloon pump in her. Systemic vascular resistance improved. She was actually walking 3 to 4 laps around the hallway. We were actually able to, we still kept her on the milrinone. We didn't really, sometimes we drop it down to 0.25. She was still tachycardic. A lot of times these patients who are well compensated, acute on chronic decompensation, really do well with a little bit of nudging, afterload reduction, good peripheral circulation, they do well. So something to always think about. And then we try to shun away from groin. That's the biggest challenge, right? Once you put that in, when do you take it out? We don't know. So that biggest, they're stuck in the bed. So if you can try and, have you done axillary? No. So, I mean, usually we call the surgeons in, they do a little cut down, they put a little scaffolding in there, and then they pass the IABP in. We do have complications with IABP, there's no question about it. It moves. Irrespective of how well you anchor, it keeps moving. So you really have to do a chest x-ray every day, monitor that. And the balloons burst. I mean, and it's a big chore. You have to take it back to the operating room if you have an axillary put that back in, and then readjust. So we did that 3 times because she waited almost 3 weeks to 4 weeks on a balloon pump, trying to see if we can get a heart first before we decided on the LVAD. So then we started slowly getting everything together, say, you know what, we're gonna do an LVAD, we can't wait like this. So after 4 weeks, she ended up getting an LVAD, and she's really doing well, not been readmitted, walking around. We still get them back on some of the guideline therapy to help her right heart. Right heart performed really well, no issues at all. That's my spiel for a balloon pump. So, you know about these trials. We talked about this SHOCK 1 and SHOCK 2. It was a very small number of patients here. When they came to SHOCK 2, it's almost like 300 patients allotted to either intra-aortic balloon pump. Really, overall outcomes is really not that much. Once again, these are the real world and the trial patients are completely different, completely different. So I think you have to pick and choose what patient would benefit. Knowing the hemodynamics is not a bad idea. But at the time when you know there's an acute decompensation of the heart, no blood pressures, you're trying to work on the coronaries while it's in the cath lab, put on a balloon pump. You can always increase it to, because those patients are not dilated, majority of the times, unless they've had ischemic cardiomyopathy, you have another artery that went down, that's a different story. They're not majority dilated. Put on a balloon pump. The benefit you will get is enormous, So don't wait for that to happen. If you know it's already sick, the blood pressure, you're already adding an inotrope, you're throwing in a vasopressor, add a balloon pump. You can always safely take it out within 24 to 48 hours.
Were angry at balloon pump. Why did they?
It's an American company.
Class 3 is pretty strong.
Yeah. So we still, I guess only for pure cardiogenic shock, they feel like that's not going to be sufficient. That's not going to be sufficient. We're talking about before they go into D&E. We're talking about maybe BNC areas. So definitely there's a value at that level for you to use that. And we'll know more about it as they you get more granular data. I think assessing that will definitely help. And majority of these, the SHOCK 1 and 2, the biggest issue, they're all acute, exactly. They're all acute. So the other thing is, when you look at the comparison, I think I have a slide for that, comparison of balloon pump versus Impella, there's no outcome difference between whatever you use. There's nothing, no difference, 30 years, et cetera. But the biggest challenge is complication rate. That was very glaring. So the Impella definitely had higher complication rate than balloon pump. There's no question about it. And like I said, there are times that we have actually one patient who's on one-to-one augmentation. So this lady, 75-year-old lady, had BIVICD. The LV lead was not working. They could not reposition it, et cetera. Okay, then they said, okay, maybe one of your patients, I don't know, we'll put in an epicardial lead. So they took her directly to the cath lab, to the operating room. Her labs were perfect. Creatinine over 1.6. Sodium was fine. Blood pressure was good. She was on optimal medical therapy. Before they took her to the OR, they did labs. Her creatinine is 3.5. Her sodium was 129. LFTs were slightly elevated, 150, 200. They took her to the OR. Surprised the anesthesia said, okay. They operated on her, brought back, creatinine is 6. Sodium is down, blood pressure is low. Then they started on, milrinone and dobutamine actually. So at that point, what do you do? The creatinine is high. So she's in shock now. So she's in D. What do you do at that point? Okay, what would you put?
Wi-Fi.
I mean, once.
So our LV is about
Get some back.
6.2 centimeter, not much of MR. We have a Swan-Ganz catheter in there. Her wedge pressure is 24. CVP is now climbing up to 14 and 16.
That would be a good patient for it now.
Yeah, fine.
Yeah,
Because, you know,
5 with
5.
continuous renal replacement therapy.
So what we did, so we ended up putting in an axillary balloon pump in her also. She's 75. Her risk of just acute kidney injury all of a sudden, because 1.6 just a week ago, right? So I'm hoping that she's not going to churn up more red blood cells, cause more clots, worsen her kidney function, and then she's never going to come off dialysis. That was one of the concerns. We're still hoping that she's going to have renal recovery eventually. So we definitely got an HT line right off the bat, started dialyzing her because of urine output. Remember we talked about urine output. Once that comes down to 30 or less, you're not making urine, you got to act. That's when it goes to D and E. No return. No return. So urine output is such an important thing as kidneys, kidneys, kidneys. So once you see that, just act on it. Put her on CRT. That reverses a lot of the acid-base disturbance, and your peripheral circulation definitely improves. Acid-base balancing. Just act on it. It's so easy to take them off CRT. No big deal. You know, take them off. Slow down the CRT. Put them on diuretics once they recover. They'll start peeing. They'll start peeing. So we ended up putting balloon pump. Actually helped her a lot. Her index improved quite a bit. She woke up. She was like mental obtundation with no very low output. So then it gets confusing when they're coming off from the OR. Is it anesthesia or they're really having low cardiac output? Don't second guess. Just do it, what you have to do. So, and she didn't require any additional support after that. She woke up. She's now sitting up, requiring less of inotrope. She's still on CRT. We're going to try and see if we can jumpstart her kidney with higher doses of diuretics and see if she's going to do better. So a lot of times when they're elderly people, you're worried about, and she's not on anticoagulation because she has some bleeding issues in the pocket. Fine. No clot. We didn't have to worry about putting on her Impella and then put her on anticoagulation, et cetera. Plus, we didn't know where she was going to go. Because if you have kidney problem and heart problem, age 75, she's not a transplant candidate. And she's not an LVAD candidate either once you have kidney failure. Because of very high mortality just doing an LVAD in an elderly patient with renal failure going into LVAD. Very high mortality. Correct.
Just patients who you put balloon pump for long period of time, do you use heparin regularly? How do you?
We do. If there's no issues of bleeding, we will definitely anticoagulate her. Correct. Correct. And then if you drop down the balloon to 1 to 2, definitely want to anticoagulate because his clots are real.
1 to 1, you can have several days without anticoagulation.
But sheet, they develop sheet clots. You develop clots in the sheets if you have.
Oh, yeah, everywhere.
So
around the balloon, you'll have clots. You'll have clots even there. This also this shock registry also came up with a shock risk score that you can look at some of the things you've heard over and over about what are some of the things you have to worry about, monitoring at the same time, assess how their risks are, and see if there's anything addition to just the inotropes that you can help these patients with. So this is look at this, 1960, but we still didn't start using it in 2000. All of a sudden, it's already, with the advent of every new device, this is going to keep going back in the shelf, right? You don't never pick up. But really, I think there's value to this patients, and you have to pick and choose wisely. There's no question about it. I mean, there's definitely benefits that you could use it, especially if you have underlying coronary artery disease and the LV is not severely dilated. This is still a great benefit. Okay. I think you guys already know these things. And there's definitely augmentation. Boy, Dr. Roach did such a fabulous job. I don't think I could have done that. So there's definitely augmentation of cardiac output, even though you don't see that at the true output, but just the benefits you get with that. And there's definitely leftward and lower shift of your pressure volume loop, which definitely benefits the patient in overall perfusion. Okay, that doesn't mean I'm going to belittle Impella. Okay, go ahead.
A quick question about outpatient heart failure medicines. When you start seeing that the blood pressure is going down and you are facing the situation of de-escalating their medications, what are your thoughts on midodrine? Do you, because that's another big thing that we certainly face in day-to-day practice, that their blood pressure is 90. Do I add midodrine so that I can adjust or keep them on the heart failure medicines, or do I de-escalate their heart failure medicines?
Yeah, I mean, that's a great point. So we don't know how midodrine works truly, but it works. So yes, I mean, if you start adding midodrine to keep their blood pressure to augment or add guideline therapy, there's no data on that, number one. Number two is I think that's the time when you have to really look at a right heart cath. We also do what we call cardiopulmonary stress test. You guys are familiar with that, right? That's another thing. That's a very simple thing other than asking how the patient is doing. Just put him on a stress test and follow that old value that you had 6 months ago to the current one. That'll automatically tell you if it's down by 30%, 40% of what their functional capacity is, if they're anaerobic onset. So once they start exercising, you build up lactate, right? So if your cardiac output is not sufficient to clear the lactate, your onset of lactate accumulation is much sooner in the exercise timing as opposed to what it was before. So the cutoff is like generally about 13 or 14. So if you see anaerobic threshold shift towards 8 or 9, those are really high risk patients. So that's when, once we know that result, we just end up doing a right heart cath on those patients. And we always try and encourage them to do cardiac rehab if they qualify for that. We always get their patients, even though the national referral for cardiac rehab is about 30% or less for qualified patients. Exercise does everything these medicines do. Everything.
Always used it to differentiate the type of dyspnea, pulmonary versus cardiac.
Very important.
But I've never used it in heart failure, so now you bring me another reason to use it.
Yeah, this is the #1 requirement for listing for elevator.
Because we don't have adequate testing facilities.
That's true.
I mean, right now in the banner system, it's only BMCP.
Yeah.
There's no other place in the banner system. I don't know if DDT has it at all.
St. Joe's has it.
St. Joe's, I was referring to.
But that's not enough. How many times you would send up people to St. Joe's
That
for a
was
stress
just to
test?
do, yes, I
Yeah.
agree.
No one would go.
Yeah.
No, seriously.
It's such a very simple test, but very important. And we do this in a lot of the valve patients too, so I don't know if you incorporate that as part
No,
of
I'm sort of using a stress echo as sort of the equivalent.
It's not.
You start sweating the mouth, salivating, and it's just calculating.
It's an uncomfortable test.
What year did you do that?
Huh? Long time back, when
Now
I was
it's
in the
all-
fellowship.
Now it's all better. You still sweat, but that's a different story. So we have another patient. So a 38-year-old, history of remote methamphetamine use, no coronary artery disease, presents with, this is more of an acute presentation, increasing dyspnea, weight gain. We didn't know this patient before. Blood pressure 100/64, pulse 92, oxygen 98%. No gallops on exam, JVD up to the angle of the mandible. By the way, we always examine the neck. No matter how big the patient is, how thick the neck is, you can still see the JVD. Like your point, it's so important. So I'm in the one of the block directors for the cardiology. That's the first thing I impress upon them. Look at the necks. It's like going to an ophthalmologist and he doesn't do a fundus exam. You go to a cardiologist, he didn't look at your neck. So it's as important. You will learn a lot the more you do. Exactly. People don't know how to do it. You're right.
Have a little light angulation
You
that
got
you
it.
can see
You
the
got
whole
it.
reflection.
Sometimes, you just turn on the light and you're in a shadow and you're like, look, I don't see JVD because you didn't look. Exactly right. It's shining a light, and then we do it in 90 degrees. Every time it's 90 degrees. So anything like they were talking about yesterday, and anything at the level of the clavicle or below, it's low tach. Patient is sitting up. Lower
You should
third.
not see it then. Yeah, I mean,
You should not see it.
If you see
Normal
it,
CVP is what?
7,
4, 5,
up to 7 maybe.
0 to 3. There's no pressure in there.
Yeah.
0 to 3. There's no CVP. So if you see anything about the clavicle, it's high. So lower third, 10 to 13, 14, 14 to 18, about 18. So just cut it. See, if you see it sitting up, so that way you don't have to worry about 45 degrees, 50 degrees, what was it yesterday, is today. So 90 degrees, even in the clinic, you can just incorporate that. It's the easiest way to look at it. Sitting, exactly, so it's easier. And that's been validated with right heart cath, sitting up 90 degrees. So no gallops, warm extremities, anasarca present. So we started them on bumetanide drip, 1 milligram an hour. Milrinone was also started. Daily chlorothiazide was given. Paroxysm, I'm sure that you had a right heart cath in here, which I didn't mention here. Lost about 15 pounds in 3 days. It was pretty good response. So preserve renal function, transaminases and bilirubin, normal lactate, everything normalized. So echocardiogram EF is 10%. RV is moderate to severely reduced, okay? Day 5, he starts having, JVD is not looking good, increasing shortness of breath. The sodium sort of dwindles down to 124. BUN 32 to 64. Creatinine goes up from 1.4 to 1.9, decreasing urine output. What is it?
Use it bimextrol.
That's it, yeah.
No, but did you add
Add
chlorothiazide, not
chlorothiazide,
metolazone? Why
yeah.
not metolazone?
You could, this is just an IV
You
form.
could have
You could-
accelerated RV failure,
Yeah.
You could
which
use
is what she has now.
Yeah.
Yeah, there's nothing wrong in using metolazone. It's going to work the same way. Yeah, you're right. He's getting worse. No question about it. Okay. So the biggest challenge for us to sort of add to things was his methamphetamine use. When I say remote, it was like a few months ago that he mentioned that he was his use. So that makes it hard for us to list him for anything transplant or durable device because the insurance company will dictate that they have to go to some sort of a rehab program before they get all these devices. So that becomes a challenge just to say, well, where are we going to go from here? You put an ECMO on, you put him on, Impala, you put him on balloon pump, et cetera. Where do you go from there? So that becomes a challenge because he really has bad heart to start with. So that's that, right? Okay, let's see what happened next. So we ended up doing a right heart cath. Oh, sorry. So these are the numbers here. So this is on the milrinone, good doses of diuretics, et cetera, right? Okay. So blood pressure here is 93/51, mean of 70. Right atrial pressure, A wave 29/30. Wow, is it high? It's high. RV 46/13. Huh? Yeah. So 35. Pulmonary capillary wedge pressure. Look at that, mean 26. This is your kind of patient that you see, right? You're ready. Okay, good. PA-SAT 48%, aortic at 96%. That's low? That's low. Boy. He escalated the diuretic. He's at 1 milligram per hour. That's a pretty good dose of given tonight. Even though I've seen people go up to 2 milligram an hour, that's like, boy, I mean, that's what I say, 24 milligrams in 24 hours.
The limiting step is RV failure. So going up on the diuretic is going to make it much faster.
Okay, good point.
Unless you have intraventricular interdependency, right, and the right ventricular septum is
So
shifted into the left. In that case, I mean, consider very aggressive diuresis to unload the right ventricle. So I think it might be situation dependent, right? Where's your septum? Is this a overloaded RV that's super dilated? Your LV filling pressures are super high because of that.
So the likelihood of he having an intraventricular septum bowed towards the LV with the EF of 10% and LVDP of 35 or 25 is less. So he may have truly an RV issue. The question is, how do we unload him better? That becomes a challenge, especially when the LV is working at 10%, 8%. I mean, just sitting doing this. You can do all the augmentation you want. And then what happens to the renal perfusion pressure with the CVP of 18 to 20? So his venous pressure, the glomerular filtration rate is going to be so low that your renal perfusion pressures are going to be so low that you cannot, no matter what you do, it's going to be hard. That's a challenge. We see this a lot of times. What do you think you want to do?
Some kind of support.
No, but
specifically
the question though is, this guy is a meth addict. He is sort of end-stage biventricular cardiomyopathy. I mean, can you make him better and functional?
It may be
Is it
transient, we
transient?
don't know that.
The question is, can we bring him back from C
After
to
dilution
D?
so much, his right atrial pressure is that high.
So there is definitely MR and there is definitely DR. And both may be functional, and initially you may help with mechanical support and try to look for whether you can really help it with something like mitral clip or something. It all depends on how much is the LV dilated, how much is the MR.
I don't know if I told you what the LV, did I say the LV size? I didn't say. Anyway, it was pretty dilated.
I think this guy is beyond care.
Hospice?
Your third choice.
There's no question about palliative care. The palliative care was engaged by this time. It was done. So they come in, they talk to the family. You never know. These are the patients I would recommend strongly when a patient like this comes in, biventricular failure. I know we're going to try and do a clip and all those things, which might help, definitely help. It's going to putz around for the next 6 months, 8 months, and then it's just a matter of time. He's just going to fail again and go down.
I think in terms of his, if there is no repeated mass use afterwards, and you don't know how these guys are going to behave.
You're right.
You don't know what is the
You got it.
historical perspective
You got it.
of these individuals.
Right.
When there is no math available in the hospital.
Yeah. Yeah, the recidivism is quite high in these patients. They just fall right down.
Some of them resolve actually.
Well, some of them
I've
are-
never seen it at this stage.
So what do you want to do now? I mean, he's like, when you look at him, he's like, okay, Dad, I'll do okay. Sitting in there. This is truly the fact. So he's not ready to run. So.
His diastolic or his diastolic home rate gradient across the circuit there is 0. That's
There.
interesting. Is that something you see?
We see that.
Quite a bit?
We see that.
It's interesting.
Yeah.
No, it's just on the edge of the
That's exactly what it is.
It's clearly a morbid dysfunction. I've never seen it.
I think he got a chance with MCS with Impella.
This is what we have.
No, I think Impella.
Put an intra-aortic balloon pump and still help him with some vasopressors and diuretics.
I'd probably go for Impella, given the amount of volume overload he has. And he may need a bipella because of the RV failure as well. Because I'm not sure balloon pump will provide enough of decongestion.
Well, what's your exit strategy?
We don't know that yet. That's what the
Temporary.
Because we don't know that. I don't think that's all hope is lost yet.
So with amphetamine use, he won't be a transplant candidate for a very long time, right?
No, it won't be because of that use.
So it's been a few months since he last used, and this is exactly the kind of situation that all of us face. What do we do? I know we have things we can do, but what's the right next best to take him to? The so-called exit strategy is to say, what else can we do? Because you could do an Impella, you could do a balloon pump. What next is the question? Because this heart is not going to recover to the point that he's going to have a reasonable life after he leaves the hospital, if he ever leaves the hospital.
So the question is, if we can bring him from a C to a B and have him refined for the next 6 months, then he is potentially a candidate.
Yeah, no, that's a great point. It's a great point. The question is, does he have the time? 6 months. That's perfect. If that works out like that, perfect.
Like in our situation, we're not advanced heart failure specialists, so we would just defer on doing something and then calling a colleague and talking to them on the phone and saying, hey, what do you think about what we've done? I mean, I don't think we would ever be faulted for trying to support a patient to make a decision with a group effort.
Completely agree. Everybody knows why we want to do something. So now we have 3 options: VA ECMO, IABP, Impella.
Pro-Tech Duo
Okay.
and a little aggressive.
So then we looked at it, exactly what you said. This is a huge multidisciplinary conference. You have the surgeons, you have the social workers, you have everybody who's talked to the family, talked to their mom, talked to the brother. What kind of support do they have? Has he used drugs? So it's a whole bunch of things that sort of goes in the background to determine, where we're going to go next. So we kind of decided, okay, well, you know what? He's not going to do well. Okay, we'll put in an Impella or we'll put in a balloon pump, et cetera. Make his hemodynamics a little bit better. Is he a candidate for at least an LVAD to start with? That was the big question that we had. So with that RV, everybody's so concerned about RV, his PAPI is so low, et cetera. So we didn't know if this is all related to left side or right side. I'm surprised so many times, but all the information we have with PAPI and TAPSEs and longitudinal strain of RV, we are not perfect in assessing what the RV does after an LVAD. We've had beautiful numbers before we did surgery. With an LVAD in, boy, he's floored RV failure. So we've had both ways go back and forth. But when somebody has such a huge dilated ventricle with elevated filling pressures on the left side, the best way that we thought we were going to go was, okay, we talked about it. Temporary mechanical such as, so we talked about this, right? So we don't want to list them for transplant for all the, increasing milrinone is not going to help. What do you think? His pressure is already low, you keep going up on it, it's not going to help. Switching oral, anything oral IV is not going to work, so continued bumetanide, not going to help. So this is what we did. So we ended up putting in, so the biggest question that we had was, what is the RV going to do? The only way to find out is to mimic an LVAD. This is the only thing that can mimic an LVAD. So we put in 5.5 through, once again, a cut down axillary, and then pass the Impella through, boy, I mean, it was an immediate effect, believe it or not. So he was so volume overload on both sides. So then we ended up looking at that. So impella was placed, elevated filling pressure. So that was the thing. So if the RV did well with the 5.5 impella, if it's contracting, requires just a touch of inotropic support, very likely he's going to do well was the biggest challenge. So we did that. I mean, look at that. This is real patient. I'm not making up these numbers. So within a matter of 3 days, he was up and moving around. His axilla, he's moving around. So like I said, PT is going to be critical in these patients. And RV function significantly improved, even though he required some dobutamine. So we took about 2 weeks to get everything together, financial, et cetera. And then eventually he ended up getting an LVAD after this hemodynamics. And he actually did well. So his LV shrunk quite a bit. We always have to worry about the intraventricular septum shifting too much to the left side, RV. So he left the hospital 3 weeks after the LVAD placement without any inotropes, on some medications, home. So he's not been readmitted, thank goodness.
Heard, and probably I have a patient who was on LVAD and has been explanted off LVAD afterwards, and their left ventricle completely recovers after a year or so. Have you, I'm sure.
Less than 5%.
Less than 5%.
It depends on what reversible causes that cause the LV. Once again, we keep looking at PCI, IABP versus impella. Really, the overall outcomes is not any different, but you can look at these numbers are so small. So I think we're hoping we're going to find more and more about which one is what. But I think the ultimate thing is going to be it's very, very patient dependent. Acuity of the situation, very patient dependent. Of course, the availability, right? Not everybody can put in a 5.5. We've done 5.5s here at Chandler Regional? Surgeons do, right. At Chandler Regional? Mercy Gilbert too? No, okay. So, I mean, at least our surgeons love to do it. This will give us the greatest opportunity to know exactly what the durable device is going to do for these patients. And we have the biggest challenge when you put a 5.5 is going to be size of the vessel. Some of the smaller vascular sizes, they just can't put a 5.5 impella. So then we have put an auxiliary CP or 2.5 to really help them. But we have, I mean, I'm sure you have encountered the same thing. It's just churns up the cells like anything. So the LDH starts going up, transaminases goes up, they're hemolyzing. It becomes a big challenge. And then we talked about the speed of the CPs or this one. We just leave it at the bare minimum. We follow this hemolysis labs over the 24, 48 hours. We actually turn it up. Remember, these patients do fine with 4.
Is it free?
Plasma-free hemoglobin is a send-out lab, even in our institution for some reason. It's going to take a couple of days. Just the LDH.
LDH.
It's good enough.
But if someone is in shock, their LDH is already up.
We'll go up, but eventually should come back. But if you see that swing back up to 800,000, it's not, it's not really heart failure. Yeah, plasma-free hemoglobin is a good test. Plus, you're going to have hematuria.
For most patients, that patient had signs of RV failure. Is the protocol mostly to support the LV first and then reassess the RV? And because I mentioned I do a Protect Duo and an Impella right up front. When do you know to do everything up front or sequentially or?
Boy, I mean, that's a loaded question right there. So if you suspect truly that this is going to be a problem when you go into the OR, especially if you're doing a durable device or some other things, you have to be ready with the right heart device. So there's no point in bringing him back, wait for 24 hours. You've lost the time. So I think at that point, you look at the TE, look at the RV, see what happens. You're already running like 5.5 on the Impella. The flows are really good. The LV, look at what RV happens. Look at the CVP because you have a swan in there. There's a lot of those criteria will tell you, you know what, he's going to do okay. So at that point, we decided, you know what, we're not going to do our Protect Duo. In this particular patient, we had very straightforward discussion with the family and everything else. This is just to see if this is going to benefit or not. We will not add additional devices if it's not going to do well. So
before you decided to implant the LVAD, you've done the entire psychiatric
psychosocial
situation because it takes a lot to take care of the LVAD, right?
Very much, very much. this is going to be a nightmare to take care of that patient.
Yeah.
Going back on meth and all those things.
Exactly, yes.
I think that's, so, you still want a summary? You guys are so good. So, I think the bottom line when you look at it is really a good assessment, good history, good physical exam still goes way beyond looking at labs, looking at numbers, looking at x-rays, et cetera. I think that's really gonna help. That helps me even this day. I mean, I really spend time examining these patients. I think that really, really helps the patient and helps me to make a decision on that. And then really acting, once you know these signs or red flags are popping up, I think acting early nobody will blame you for acting early. Nobody will blame you for acting early. So I think it's gonna help the patient immensely. So it's easy for you to act early and remove those devices within 24 to 48 hours, as opposed to acting late and try to keep adding, cycling your devices back and forth. That's a more dangerous thing to sort of deal with. The third thing is then once you do that, once you know the patient is stable, you might be able to explant. You don't need to transfer your patients out. You should be able to handle some of these acute MI patients. You should be able to get that out. And I would just keep this Impellas, and I know we rev it up to P8 and P9 and all those things, but I think they'll do fine with P6 and P7 a lot of times, because remember, these patients, especially acute on chronic, they've had low output all their life, but we want to give them 5 liters all of a sudden. So that, sort of dictates more complications, hemolysis, et cetera. I would sort of lower it down within 24 hours to P7, P6, let them rest for that, provide the additional support with your inotropes. Don't forget about the nutrition, because these patients are down for 4, 5, 6, 7 days. Never forget nutrition. And then if you can try and do axillary implantation with the MCS, try to do that as a first approach and get your surgeons involved right off the bat. See if they need to do additional procedures for that. Nutrition and physical therapy, I mean, I can't say much about this. It's such an important, and I know the ICU team's so right up on top, so.
Unrelated to this presentation, but we had recently a case where a patient came in with MI and she had this Takotsubo picture was hypercontractility of the base. How does the Impella interact with that? If the inflow cannula or the outflow cannula is being squeezed by the base of the ventricle?
It's okay, George. I've done one case on a Takotsubo who was with cardiogenic shock and the patient did fine. That's not a problem. We haven't seen any issues.
And the base was contracting?
Yeah, right.
Because what we noted, when we're doing the case looking into the hemodynamics.
And that patient required the device only for 2 days. In 2 days, the LV recovers. Only reason to do it is if they're in shock.
So exactly. So her pressures were low. We kept getting the suctioning. The RV was decent, the suctioning allowed. And finally, toward the end, when we pushed the Impella forward, her numbers got better, and so we were wondering that if one of the outflow is it was being squeezed by the base of the ventricle.
I don't think the base contracts to the extent that it's going to squeeze the outflow of the Impella. It should not. Right. So it should be up there. The biggest challenge that I worry about, probably better, would be the mobility of the Impella. The base squeezing that way and just it's being there, it probably can shift your Impella motion more than anything else. But short of that, it should be perfectly fine if it's in shock.
Was getting sucked into the LVOT.
Yeah, so it depends how big the ventricle was.
That's what he's saying. So it was just, every time it will take tachycardic, so it was just kind of sucking and just, we were thinking that the walls are including the holes.
The physiology is very similar to suicide left ventricle, which we see in severe LVH, aortic stenosis patients post-TAVR. We see them post-TAVRs, they become hypotensive. You rule out all your acute emergencies, put them on beta blockers. So one strategy is to, what's that? Yeah, so you put Impella and put them on beta blockers to reduce the LV contraction.
To lower the heart rate.
It's not very common, obviously. I've had one patient only, so it's.
Yeah, they generally do well within a short period of time. But if they need something, they need something. Balloon pump maybe would have been a choice for that patient. Yeah, maybe.
Yeah. But wouldn't that worsen the LV outflow tract gradient? As you decrease afterflow?
You should not have so much the pure Takotsubo.
Well, if there's an LV outflow tract gradient, wasn't that the case, George?
No, it wasn't. She came in as a little bit delayed STEMI, but the whole anterior wall and the apical wall were very down, and only the base was really hypercontracted. It looked like a Takotsubo picture, but in the setting of an acute coronary syndrome, not an ischemic situation.
Maybe your impella is closer to the apparatus of the mitral valve. You're creating Venturi effect. And that's when you pushed it down, you were able to stabilize.
That could be another mechanism, yeah.
One practical question is, so patients who are on like Kodak and stuff like that, they show up in the ICU, end up in the ICU, so you have to put some pressures. You will carry on the beta blockers?
If they're not really so hypotensive, like 80/60, and they're not on 25, 50 milligrams of chloride twice a day, I would definitely lower those patients down to 3.125 and just leave it at that.
Nice.
Unless they're really hypotensive, I'll stop everything.
Sometimes it looks stupid that you're giving them pressure, then you're giving them beta blockers. You just want to.
We just lower the doses quite a bit. And especially if they're on dobutamine, I would not leave them on beta block. There's no point in that.
Milrinone needed them in 3, right?
No,
Milrinone is different. So, how's your experience with ibradine? Ibradine.
Oh, ibradine? We have used it, not a whole lot, what level, what point to introduce that?
Yeah, I think the heart rate over 90 and they're on maximum beta blocker, that's what I mean.
Just put them on it. Or if they can't tolerate beta blocker.
If they cannot tolerate the higher dose, yeah.
Thank you, Dr.
It's still a 2B indication, so, thank you.
Thank you.
One more time, guys.
One more time.
Sorry, just one more.
One more thing.
So,
Thank you.
this hopefully this ties things together pretty well. It gives you a flavor of kind of what we're doing on a daily basis. As the ECMO and shock team, we review all these cases, have a group discussion. We're hoping to get you guys more involved in these too. What went well, what didn't go well, and what can we improve on. We try to do it every single run we do for ECMO. The team as well, the ECMO specialist, nursing can bring up concerns, things from their perspective that went well, didn't go well, improvements. So, and we really try to have an evidence-based approach to how we can improve on everything, what went well and what could have gone better. So this was a case we had. I'm sorry. I don't have any slides. I think I emailed the. I think I sent the. I can send them. Can I send it to? It's Google Slides. Can I send that? Okay. Sorry, guys. I thought I had sent it. I got to give credit to Dr. Marston. He's the one who created this presentation. He's not able to come today because he's working nights, so he has to get some sleep. Yeah. What's that? You need to go to sleep too. Gosh. He did an excellent job with this really difficult case. And we try to rotate all of our ECMO specialists through the presentation so everybody gets a chance to be in the hot seat. So these are special to when we have a run. We want to do it pretty soon after the ECMO run. So these will be unique cases outside of the regular ECMO meetings. So, yeah. I think per month. Oh, yeah, sure.
Beautiful. Sorry about that, guys. All right, we made it, guys. The last one. So hopefully this is pretty interactive too. I think there's a lot of ways to approach these cases and a lot of, I think right ways to do things. So, things were done. So this is a case at the VA, yeah. So we're going to talk about we're going to do the case. We'll talk about this. This is how we approach our reviews of the run. Okay, so we'll have a case review. We'll talk about what we did right, what needs to improve. In this particular case, we should have relied more on tags to guide our transfusions, and we'll talk more about that. How we manage differential circulations with VA ECMO. So you have the ECMO circuit that's providing a particular type of blood flow, and then you have the cardiopulmonary circulation, which is providing a very different type of blood flow with respect to oxygen. So areas of interest, Icapella, this came up during the case, and when to pull the trigger on Icapella. So 63-year-old guy, and please feel free to, this wasn't my case, so I may.
The brief clinical. So 63-year-old guy, diabetes, but no real compliance to medications. He was working at Rogers Corporation as a machinist, and he was at the water cooler and passed out, and bystander started CPR. When he came, he was in VFib and had PE arrest after that. The VFib was there was no rhythm strip to attest to the VFib, and then his rhythm came back. His first EKG actually looked like almost like a Brugada syndrome looking EKG, right bundle branch morphology, no acute STEMI looking EKG. I was concerned that this probably is not an ACS and it's primary arrhythmic arrest. Given his age and his neurostatus being intact, based on the ER evaluation, decided to take him to the cath lab. He was on 20 of epi at that time. Did the coronary angiogram, and he had severe 99% distal left main stenosis, ostial LAD, ostial circumflex, occluded distal RCA, and his EDP was I think around 25 to 30, and his rhythm changed, his complex became wide, and he seemed to be in slow ventricular tachycardia throughout this. He was already intubated, and at that point the decision making was that should I put in Impella and proceed with high-risk PCI. I already called the surgeons as soon as I saw the angiogram. The surgeons were operating, so they were not available at that exact moment. And while this was all happening, we noticed that he's desaturating and hypoxic on 100% FiO2 on the ventilator, and his breathing was asynchronous to the ventilator as well. So at that point we decided to proceed with ECMO, VA ECMO, and proceed with intervention. And throughout the intervention, he remained in a weird, wide, complex rhythm, unsure whether it's because of the acidosis or it was really VT. And then, take it from there.
Yeah, thank you. So I'm not sure of his baseline organ function. We can see the slight elevation of your ACLT and your creatinine as well. A little bit concerning. Of course, lactate of 9 is quite concerning. pH of 7.15, PCO2 of 59. Some acid-base abnormalities clearly there. So these are thromboelastographs, and this may not be exactly in the cardiology world used too much because of just.
How long does it take to do this? Is it an outside test or does it happen?
No, so you buy a lot of people are like kind of afraid to do this because like, oh, this is going to be a very expensive test. The machine is expensive, but the test is incredibly cheap, and it's done in-house. Yeah, so we do these in-house. Yeah, yep, and it's beautiful because it gives you an entire coagulation and platelet assay, everything all at once. Because, like we talked about in the previous presentation, relying on an ACT is you're trying to make a broad sweeping assessment of the entire coagulation cascade with one number, and it ends up when you're trying to manage these complex VA ECMO cases on a day-to-day basis. It's very important to be nuanced of what you're transfusing. More transfusions causes a lot more issues. The R time is the time to create an initial clot. Okay, 5 to 10 is approximately normal. And this is how quickly you're breaking down the clot. So very quickly, endogenous TPA, endogenous lytic lysis of the clot is very avid. CFF, this is basically how you assess your fibrin stranding. So practically speaking, you can use this data to say, okay, I've got an extremely long prolonged R time, right? In the absence of, you can do CKH, which is CK heparinase. So you add heparinase to the blood, and it'll negate the effect of the heparin. And if that is prolonged, then you know you need to transfuse FFP because there's some sort of coagulopathy going on. If your CFF is extremely low and they're bleeding, then you want to transfuse cryo, right? So you can get very granular in particular about it. You can also, MA is also, I think it's CRT on this newer assay where you assess your platelet function. And then you have to, there's quite a few reasons why you can have platelet dysfunction, particularly in the cath lab. But there kind of needs to be a little more in-depth digging for platelet function.
So a good anticoagulated person, how will their profile look like?
So it looked like a wine glass, so the flute would be like a champagne flute. I'd be concerned that you can have like platelet dysfunction, like this is like narrow, so kind of more like a nice bowl to a wine glass, right? Like a Cabernet glass or something like that, I guess. So, but if champagne, if it's like really, you get that first line that comes out and then it's very narrow and not very tall, that suggests, generally speaking, platelet dysfunction. So I think a nice generous bowl to a Cabernet glass maybe is the best way to, and we'll have some more examples. And here's the EKG that you had mentioned here.
Look at, yeah, but there is right bundle branch block and ST elevation in the lateral leads, but this was the first EKG.
Not good, not great. There's an ET tube at this point. Obviously some pulmonary edema, probably some other, right upper lobe doesn't look great too, so maybe aspiration on top of it. Take it to the cath lab. So we did, in here, we're not, again, the point of this is not to say you did this or you didn't do this. This is really just to review what happened, what we can do better. And I think we've kind of already been talking about it. I think what we can do better is get called earlier, right? I think that's just kind of the point of this statement is like, we're in the cath lab and you're on epi at 20. I don't know the acuity of the situation, but perhaps, an earlier call just so we can get involved a little earlier would be prudent. But I don't know exactly how that played out. So, but we found out through the charge nurse who had heard that there was somebody in the cath lab on epi at 20. So ICU went to the cath lab to see if they could help. By then, there were plans to put tandem life support during the case with, I guess, the bridge to recovery. So expect full recovery was the plan. Noted to have severe multivessel disease. Pressors were stable. I was getting bicarb to help with the acidemia. Again, that's something we can help you guys with there.
Normal, or we don't know the answer?
We don't know that yet.
We don't know that.
Actually, I did an LV gram. The EF appeared to be 40-45. Okay. Yep.
A 45.
Don't remember. Yeah. He was started on LV in the ER itself. So.
Started on, and I think that's another avenue too. We need to probably have like we were talking to George about getting the ED involved too, I think. So having notification from there. So started on tandem life, which is VA ECMO. There you go, yeah. LVEDP, so we're not unloading super well, obviously. We got LVEDP of 35, where it's a high filling pressure.
Must have been in the tank when you guys made that decision to start VA ECMO. It was just like.
I think he was 80. No, I think on the epi he was 90s epi. Systolic was 90s, but he was on plenty of epi, and he was hypoxic by the time we started doing the intervention.
So here's the severe multivessel disease we were talking about there. And Dr. Shaw, I think you were the interventionalist who did the procedure. So obviously got intervened upon here, stented, aspirin Belinta. So I think we're called back to the cath lab. We had some issues with refractory VT. We alluded to that. Severe acidemia.
For the night into the next day.
Yeah. Getting bicarb pushes, amio, lidocaine, drips of all three of those things, calcium, magnesium, up to, at this point, norepi of 40, vaso 0.03, and your tandem is flowing at 5 liters, which is pretty good. So.
It went on the tandem light, or
This is on tandem.
on tandem?
All
Yeah.
simultaneously.
So there's a problem, right? We put them on for LV support, and it's not going well. We're adding more pressors going up on everything. pH is near 7, so we've got a lot of work to do to get that acid base under control. Adjusting the ventilator and the sweep, I think we went up to sweep of 5 at that point. Yeah, Norepinephrine, vaso, and epi still. So he was moving his arms, which is something we like to see. I mean,
Do you guys add lidocaine at that point?
he's on a lidocaine drip.
Yeah.
Yes. He got ambiobolosis ×3. He got calcium thrown at, magnesium, bicarb, everything you can think of for the kitchen sink. He was on a lidocaine drip. In fact, EP came in and did a semi-permanent atrial lead to overdrive the VT, which still didn't help. So he was thoroughly in VT storm.
So overdrive phase replace.
At this point, I mean, so at this point you've already intervened on him?
Yeah.
You already intervened on him. Was there not a candidate for bypass?
Well, I mean, at that point when he is on 3 pressors, toxic.
You know, you took
No,
a
it
breath
was all happening in real time. The surgeons were called right as soon as I did the angiogram. The surgeons were called.
Okay.
Yeah, they were not
Because,
available
you know,
for review.
if it's 40, right, you put him on VA ECMO, you buy some time, you know, it's got multi-vessel disease, so hopefully everything is viable. I'm just saying, you know,
Yeah,
that.
yeah. I mean, that's why my first call was to the surgeon actually, looking at
Okay.
the anatomy. You know.
A surgeon's not going to touch him.
Yeah.
Well, why not? This would be a perfect patient for them. Multi-vessel disease, EF is not bad, you know, he's already suffered on VA.
Cardiogenic shock physically motion.
Well, there were other issues
No, but
going
you
on
sort
too.
of
So.
put him on a device to help with that, right? I mean, if the LV is infarcted, a portion of it is infarcted, then that would have been a different story. All the vessels are
Is it
open.
possible to play the video? If you click on it? Yeah, so there were other issues going on at the time too, which we'll get into. It was a pretty complicated case.
It's asking for full drive access to play the video.
Oh, looking range of access here. Sorry, guys.
Is this immediately post CAT?
You know what, I think this is going to be accessible because that's Dr. Marston's video actually, so it's going to go to his email. So, post-cat echo, yeah. So we're not going to have access to it, unfortunately.
You can summarize it.
I can tell you what it showed.
Yeah.
Go ahead.
So the RV was completely collapsed around it, and the LV was looking like a 15% ejection fraction at
That
that
was
point.
immediately after once he came to the ICU. So his EF was 45% in the cath lab, dropped to 15%, but with a collapsed RV.
Well, the EDP was 35, so I'm pretty sure the ECMO made it worse, right? That could have been the other problem.
So, of course, during this presentation, we went into the stages of this guy shock model here. And clearly this patient was pretty sick, so, you know, E essentially. Sure, yeah.
Because of hypoxia component and
Hypoxia.
not impella because of that?
So hypoxia already on 3 pressors, impella may not provide enough support.
Was the patient intubated by that time?
Yeah, he was intubated in the ER. He had a PR.
He coded, was intubated in the field, and then went directly to the cath lab.
For you guys, it's easy to put an ECMO than an impella. I mean, I'm
No,
just asking.
no, I think I would say it's easier to put impella than ECMO.
Yeah.
Experience is growing for the cath lab staff, so depending on the user experience and the particular cath lab staff, I would say the delta is not as much as it was few months back, but still at 2 a.m. It's probably easier to put an impella than an ECMO. This was in daytime, so we had more resources available, and Dr. Prashad had come in to help with this case. So
So we talked about that, and we also talked. We brought up the shock protocol, and kind of we mentioned again is like, hey, you know, we're getting called when they've already decided to put the device in, and we just kind of wish we were called a little bit earlier, but it was what it was at the time. And this is kind of the cardiogenic shock protocol we've developed, at least from the intensivist perspective here. This is kind of what we're dealing with on a daily basis. The labs we're getting, the assessments and the ongoing sort of reassessment of where they're at, what their needs are, and how they're progressing.
Algorithm is shared with the cardiologist.
Yeah, so it's,
At which point?
We sent it like months ago. I mean, it was sent, we presented the cardiovascular department meeting, it was presented the all members meeting, but we'll reshare it again. A quick question here for you and Dr. Kalia. So this is the algorithm, but when do you see, like in this case, the typical example, you see Impella won't be enough support, let's go straight to VA ECMO. When do you bypass this algorithm and say, I want to go VA ECMO or 5.5, and, you know, not wait to, you know, go through this algorithm?
good question. Yeah, and I think it's similar to what was been asked before. Like, it depends on the acuity, right? If this is a hot and heavy crash and burn, you don't have time to go through the algorithm and, hey, what's my PAPI after I did a therapeutic intervention, and then reassess that. And so it's just, I think it's one of those, like, if this is a hot and heavy crash and burn like the one we just put up, he's coding or, you know, just about to code, there's just no time to get the SWAN and the numbers and try an intervention and, you know, be conservative and then reassess and all that. So
one of the really important check boxes is that he is a witnessed arrest, had CPR, had evidence of neurologic function still going in. Because some of these arrests that don't have those type of things, we won't jump to crash them onto it.
good point. Yeah, thank you. Thank you for pointing that out. Good point.
Arrest patient with the good features, think should go straight to VA ECMO or still go through the algorithm?
Again, I mean, if you're getting them back, you have some sort of stability. I mean, if it's ECPR and they're still coding, that's a different animal, right? But if arrested, you've gotten ROSC after 5-10 minutes, their blood pressure is stable, as if, you know, just it's so situationally dependent, you'd have to.
Yes, storm, you know, happening.
So then, if you get the right patient, the right clinical scenario, I think crashing on ECMO is okay.
This is a DNE patient, so really, I don't know if Impella alone is going to be sufficient, but that's one thing. But I was just thinking about I mean, looking at the hemodynamics and everything, left atrial cannulation might have been better, especially if you already have hypoxia from pulmonary edema, and now you're doing a VA ECMO with higher LVEDP. Now the pulmonary edema is not going to get any better. His left atrial pressure is going to be sky high. So he needed, at this point, somehow, I know it's just happening, I mean, there's so many things happening, he's coding right now, so it's going to be hard to think that way, but definitely it's definitely not going to help his hypoxia anymore. So I think the left atrial cannulation would have been better. Just hindsight. So.
Large anterior MI. So, and then you picked up VA ECMO as the first therapy. So just for the same reason, like LVEDP will go sky high, and things will get worse. You know, I presume if as I continue the procedure. Do you think that's how will you handle that situation then?
So yeah, I mean, and then I think I'm sure that's part of the Kris's presentation is the purpose of VA ECMO in this case was not so much to rest the heart or recover. It was just to survive. It was more of a survival instinct in this case, and then we will figure it out. What do we do next? I'm sure Impella was in the talks and upgrading into something else. So at that moment, in fact, I didn't even have a right heart cath by the time we did the ECMO. We didn't even have that. I don't even remember what the CPO was on this one.
I'm sorry, I didn't mean it this way. I'm just trying to.
No, I'm saying that
for my
your
own
point.
On my own understanding that if the next person rolls in the cath lab, and how should be our thinking? So my first priority will be to support LV. That's what I'm thinking. With the Impella would be, or a balloon pump would be the two choices I'll go for predominantly. If the oxygenation, I know his lungs are okay. Once I put him on a breathing machine, he should be all right. And so the next thing I have to worry is the LV function. So LV function I know is 4, or will be 4 once I open the artery further, and temporarily. So that's how I would think. So, but I know for this case I'm okay with how you presented. But am I on the right track? Just ask me.
Yeah. In this case, he was still profoundly hypoxic, even on the ventilator with maximized ventilation. That the
Okay,
SACS
so that's good, okay, that's good.
Yeah, so that was a big part of why it just went straight kind of to VA ECMO.
It's unusual that you have profound, like not reversible hypoxemia in a VA case.
But that's another reason to get us down there, because you know, your respiratory therapists are well versed in a lot of types of ventilation that other people besides the intensivists may not use. Like this patient, I think we threw him on APRV, and that's not something that you guys would think to jump to, because that's not your wheelhouse. So just having us down there can help out. But also, one of the things I want to point out, Kris was saying, like, you know, things that are happening really quickly, like for some of these people, we can just throw them on. But you need an intensivist there to know if we can just throw them on, because like Prashad brought up the other day, somebody got put on some system and we didn't have anywhere to put them. We didn't have nurses ready to take that, we didn't have a perfusionist. So you need an intensivist to be like, we can't do that, we have to do Impella or we have to do this.
Yeah. So do we have a coordinator at the facility to say?
We do. So we have ECMO coordinators. We've got everybody on a Slack line that the intensivists are all talking to. If you just activate an intensivist, they'll come to the cath lab to help run the code, do the airways, manage that stuff, and they'll send out a message on the Slack line, and we'll get to work on the rest of it.
I think the missing piece is the ER, because patients like this
Yeah.
person coming to the ER for cardiac arrest, possible STEMI, the call is going to us first, not to the.
The STEMI is the exciting part. The STEMI has the door to balloon time, and so they need to call you right away. And once it's in your hands, they're not focused on it anymore.
Yeah, okay. Yeah, and I think it's going to be takes education to the EL. I don't think they know exactly what we have to offer. Yes, we've already seen some good movement, right? You know, it's changing. It's definitely improving. So I guess at phenylephrine, try to reduce going to these tachyarrhythmias, reduce any sort of beta agonism possible in ischemic heart, and obviously with VT storm, it's going to be prudent. So one thing we noticed was a lot of chugging on the circuit. We kind of showed a video of that earlier, kind of a telltale sign, most likely going to be volume down, but of course you need to assess for cannula positioning and other kinds of bad stuff like that. But there was tons of bleeding from the right groin access site.
Just an 8 French sheaths that we left in place, anticipating that he's going to need Impella. So the left groin was the arterial cannula, right groin arterial sheath was left in place with the expectation that we're going to bring him back for Impella. We already have an access, so if you have to bring him back, it's going to be pretty quick.
Okay, so now we're getting some more data points. We're seeing an underfilled right ventricle. We're seeing chugging on the ECMO circuit in good cannula position, and we're having this bleeding. So we're like, okay, well, this is probably a volume issue at this point. So gave 2 units of packed red blood cells. Tons of thick secretions coming from the ET tube, put on antibiotics for that. So the ECMO settings initially ramped up to 5,000 RPM, getting 3.3 liters of flow out of that, sweep 3. These are the ventilator settings. Gas. So it's really important. One of the really difficult things for VA ECMO management is you have to manage the differential circulations, right? So we always have at least 2 blood gases, ideally 3 because we get SWAN numbers too. But your patient, right radial is usually what we get, right? And that's what's the surrogate for coronary, right? Coronary perfusion as well as cerebral perfusion, which is also a big deal, right? So we want to worry about that, and we manage that with the ventilator. And then the post-oxygenator is how we manage the oxygenator circuit or the ECMO circuit. And it's very important, very, very important to differentiate between the two, because if you don't pay attention to that, you can cause differential hypoxia, Harlequin syndrome, cerebral anoxia, and coronary anoxia as well, or hypoxia.
Where are you going to see the difference? Which one, in the patient?
Great question. Yes, your PO2 in the patient is going to be really low. Or you can literally, like the upper part of their body just turns purple and blue. It's pretty frightening,
So
actually.
despite this, his mixed venous is so low, so that he still is in profound shock.
Yeah, he's in trouble, for sure, yeah.
And can you go over the treatment for Harlequin? Again, you beta block them or you turn down the flow rate?
There's a ton, it's going to be clinically, I'm going to do the cop-out answer again.
Yeah.
It depends on the clinical situation, yeah. So if you want them to be more pulsatile, you can turn on ECMO flow.
Right.
Try turning on ECMO flow. You can add inotropy. You could beta block them so that the
so you
ECMO is
that mixing area closer to
exactly. So you just kind of mess with that mixing cloud in various ways. So it's
But he was
tricky.
still on 3 pressors with amio and lido drips at this time.
Hey, Deval, if in your retrospectoscope, if you were to go back on this case, would you go to ECPella
Hold that thought, hold that thought.
Okay. Sorry.
You guys are jumping there, yeah.
Sorry.
This
It's
is
okay.
day zero.
No, I mean, that's what we commonly do, so this kind of seems very unusual to us. See, cardiac output is 3.3.
Yeah.
You have profound shock with mixed venous that low.
But
Why would
again-
we not put any color this case?
Again, the bleeding, the patient, the RV is severely
That would be
underflow,
a
chugging
perfect
the
time to
echoes,
put
okay.
any color, because it would take care of the bleeding, because the bleeding is happening around the sheet probably.
Fair, yeah, fair. I guess my point is that it's a mixed shock picker at the moment.
Oh,
We're
right,
trying to-
at this point, yeah, with the acute.
Yeah, so we're
We're
still
only
dealing
an hour
with the.
into it at this point. Like they did all of this stuff in like 60 to 90 minutes. So they got a lot done really fast, and they were still just getting data points here.
Yeah,
This,
so,
the time frame is literally less than 4 hours, so we are not sure which way we are heading yet.
All right, of course.
but this is where we jump into the retrospective scope and say, like, what can we do differently, what can we do better? Because in the heat of the moment, you're trying to keep the patient alive, right?
You guys are amazing. I mean, this is works so fast. It's happening. It's unbelievable.
Yeah, and there's a million data points flying at you
I agree.
very quickly.
Yeah, the intervention was just a nightmare too. It was calcified disease. It was rotoing two vessels. I was watching. It was pretty amazing.
So we turned down the flows because there's so much chugging and the patient was so underresuscitated. We're trying to catch up, giving them volume. Lactate's not getting better, it's 9.9. Fully anticoagulated, given a bolus dose of 24,000 over 2 hours and a 12 mics per kg per hour. Fibrinogen is 177, INR is 1.9. ACT 22, XA level is 1.8. AT3 levels, these are all things we're following
What
regularly.
about ACT, the number we know?
I think before we cannulate, I make sure we have a decently high ACT, but after that, I completely ignore ACT, like altogether. So it's helpful in the heat of the moment, perhaps, but it's really, so this was something we can improve on. We didn't do that well, we can do it better. So again, we had the CK, that's the time to form this initial clot, okay? Actually, the red's not on there, so maybe it's all the way out here. So it's a super long R time, but when you negate so this is, you're on heparin, right? So you're definitely anticoagulated, the heparin's working good, but what happens when we negate the heparin? Well, we're still prolonged, so we have an underlying coagulopathy that's not been corrected. And then your MA, so your platelets, of course, are on dual antiplatelet and all that stuff. So their MA is, their platelet function's minimal. So and the CFF, I don't know why it wasn't measured down there. CFF should be on there. That's the fibrin assay. So we pause the heparin. Obviously, the XA is markedly prolonged, and our time with heparin is prolonged as well. Eventually resumed. So kept dumping blood into him, kept resuscitating. Up to this point, we're up to 6 units of blood. This is the next TEG. So at this point, we're seeing.
First TEG and this TEG.
About 6 or 8 hours.
6 or 8 hours.
Yeah.
In the meantime, did you guys get a CT or anything to see if he's having retroperitoneal hematoma? Where is the blood going?
I don't think so. Yeah, I don't think so.
I mean, it must be bleeding from somewhere, right?
I think it was
He
this.
was bleeding from his groin, and they had lost
Like
a lot of blood
outside?
earlier that we couldn't really see because the first blood draw that you saw was 9.8. We gave 2 units because we knew he was bleeding. It wasn't diluted yet. So we had just finished giving that blood when we rechecked it and saw this, and he was having a lot of issues with his blood pressure and chugging at that time as well. So we knew that he was losing volume, redistributed.
And the RV was like a slip. So, so there was a major issue with the volume. And we thought, the ICU team thought that the best way to give volume back was blood based on the other parameters.
Yeah,
and the oozing going on in the groin.
Yeah.
It was all external, you could see it was not, it wasn't
We were
invisible,
putting TXA on it too.
But doesn't matter if it is bleeding that much, why do you guys not upgrade the sheet or do an angiogram to see your laboratory?
Well, to be honest, he wasn't bleeding that much that we had to give so many products to catch up with the bleed. I think it was more so the volume that he needed, and blood was the product to be chosen to give the volume. He was not bleeding profusely.
I see.
And if you see his hemoglobin trends, actually, his hemoglobin trends are not bad at all. Right?
No, absolutely.
But keep in mind that hemoglobin 6, I think, was after 6 units of blood were given too. So that's another part. So here we're looking at the CK heparinase on the higher end of normal. So all your anticoagulation, all your R time is accounted for mostly by heparin. You could make the argument there's a slight elevation in there's a slight underlying coagulopathy in the absence of heparin. The CFF, that's our fibrin assay. I think we neglected this. It's undetectable activity of fibrin. So the R time is okay, you're making that initial clot, but what you're not doing is you're not forming a fibrin mesh, right? So we should have transfused cryoprecipitate here. Here's our labs. Not terrible for the clinical situation, but now we've got a lactate that's coming down. AST, ALT are still hanging in there. Creatinine remarkably is better. So
4 to 0.9.
This came down.
Yep.
It's remarkable.
yeah.
Yep.
So at this point we're still only running at 2.5 liters. Sweet gas at 4. Ventilator settings. So this is a bit of a problem that we talked about and we recognized and started to pay a lot more attention to. So our patient gas, you guys see a problem with the patient gas, right? Yeah, so your PaO2 is on the lower side. That's not good. And the post-oxy gas is great. I mean, you want to see a PaO2 past the oxygenator of anything above like 200 is good. If you start to see that.
To the LFTs and the renal function, because the cardiac output the day before was 3.3, right? And you had all these bleeding issues, so patient's blood pressure was labile, low. How does the AST come down and the creatinine get better?
We have an amazing team. I think that's what
off the pressure.
the resuscitative efforts from the team were amazing. Either was on the.
He was off.
I think he was on levo at 5.
Yeah,
he was on levo at 5 by the next morning. So
he was still on all the Lita. So the reason I turned his RPMs down and turned his cardiac output down was because he kept going into a VTAC storm, even though he was on the amio and the Lito. And he wasn't, like, I would throw the ultrasound on his heart. The left side, even though we gave him 6 units of blood, the right side was still completely collapsed. Left side didn't look like it was always opening all the way. Like, his heart was just a mess.
And all that stuff.
Yes, we kept losing it, and I would turn down until his heart was just beating again.
Majority.
Yeah.
Because everything else you're seeing improved with all the other circuits that's been provided. But now he was 200 something before the patient oxygenation.
Yeah, the patient
so now it's like 70. So there's something ongoing with the pulmonary issue at this point.
So with this gas, what ought to be done is addressing the PO2. You probably want to have a better patient PO2 to avoid differential hypoxia to the brain and the coronaries. The post-oxy gas needs to be turned down a bit, right? So you're blowing off a lot of CO2. You got a pretty alkalemic setup there. Flows still lower. We're having chugging issues. Are they still volume down is the big question.
You had a swan there, right? What were your right atrial pressures?
So I was on the case, so I can't tell you.
It's going to be hard because you're pulling out of the.
Yeah.
But still you should have some.
You will have some, but you already saw the RVs so collapsed like this. You don't know how to really.
Yeah, we could directly see the RV.
So when you're on ECMO, the right atrial pressure is like useless.
It's going to be tough. It's going to be tough to really assess accuracy unless you're seeing swollen up.
Oh, okay. What about PA pressures? You should still be able to infer from PA pressures, right, at the bench.
I don't know.
No, they would be reduced flow, right? Because they're picking up from the right side and coming into the left side. So actually Swan has no meaning. You're right.
The only thing we used it for
And
was
number
for
2 here, I was just going to ask you is if the post numbers are PO2 of 271 and the patient's PO2 is 72, would you not reduce the ECMO flow?
They did, that's what she was saying.
Yeah.
No, but if you reduce it completely, maybe the LV is functioning better and it will throw the blood more to the upper body.
So yeah, we're definitely conscious of hyperoxia, and we will come down to FDO2 from ECMO if necessary, if the situation can call for it. We titrate that down too. We're a little more careful with that, and we try to be gradual and slow with that because we don't run into any sort of hypoxemia issues, make anything worse. But that's a good point. So by day 1, the VTAC starts to get better controlled. We're still having intermittent loss of pulsatility, and the echo shows near cardiac standstill. So before inotropy was started, the ICU team had noted the EF was about 15%, I think.
Still happened. It was interesting that EP was trying to turn off the pacemaker to see what's going on underneath, and they turned it down for a few minutes, and he was in sinus tachycardia rhythm, and they put it back on to whatever settings they had it on, and the standstill happened 5 minutes after that. So I'm not sure it was just a coincidental thing or whatever it was, and this was just yeah. But I'm just saying that the sequence of events happened that way.
The patient was very temperamental. That was the largest loss of pulsatility, but we intermittently were having episodes of this every hour, 2 hours. That would be short-lived, but that was the largest.
So at this point, we're getting a hold of it. I think finally the perfusionist was like, hey, the CFF is low, give some fibrinogen, and we gave cryo, and the bleeding stopped. As soon as we followed the tag, somebody recognized the fibrin was a problem, gave cryo, no more bleeding, like done. So again, underlying the importance of a tag for ECMO is really, really important. So at this point, because the bleeding was stopped and we're catching up on resuscitation, finally we can go up on the flows again.
Yeah, I see. Like, why would
we had to replace so much blood volume. So like, if we were doing a massive transfusion protocol and we gave 6 units of blood, we would just instantly give some cryo and some platelets. And we didn't do that for him because it was basically a slow transfusion, so we didn't realize how much we had given.
Right.
So we almost replaced this entire blood volume, and if you just do have a packed red blood cells, well, you're not going to have any platelets, and you're not going to have all your factors, right? That are there. So FFP has some fibrin, but not much. So the major culprit was the lack of fibrin. But still high pressure requirements. So at this point, I guess this is when the Impella discussions began. Most of the concern is loss of pulsatility. Yeah.
So this the echo shows near cardiac standstill. So because of what?
Because of the ECMO.
Because the high EDP, there's so much of water.
We don't exactly know, I think, why this happened. It just happened for a few minutes, and then he was back on
When we say cardiac standstill, are we talking about LV or RV?
LV.
Due to my pressure in there?
I don't have that. Yeah, I don't even know if there was a swan. Was there a swan?
There was a swan in place, but I mean the numbers on the swan were really useful because we had back pressure kind of retrograde from the ECMO.
Yeah.
So when you have high pressures like that and your heart is so weak, it can't pump hard enough to open the aortic valve to push
But
against
that's why you
it.
need venting of the left ventricle, right? That's why you need venting of the left ventricle.
Entering Impella discussions, right? So that's, yeah.
No, but then in that case, why would you increase the ECMO flow? Why?
We decreased it. So multiple times throughout the night, the heart would just stop, and I'd come back in the room and we'd turn the ECMO all the way down until the heart would start doing something again, and then just very, very slowly we'd bring it back up over the course of like, I don't know, 45 minutes, just very slowly increasing it every 5 minutes, and then they would do well with that for maybe an hour, and then all of a sudden his heart would just stop again. So we spent a lot of time playing with that, and that's why his numbers kept going low. But when he was up higher, he was getting good perfusion of everything, and I think that's why some of his organ systems did start to turn around. He had like, Lyman and Marsden were with him all day, and then I spent all night with this guy. Like, he was very.
His trajectory was just a complete roller coaster.
No, the reason is LV is so distended, right?
Yes.
You let it go, it recovers a little bit, now you go back on, now it goes back again. So that, I mean, I'm telling you, if you had put an implant, you would not have all this trouble.
So
I mean, you already have an 8 French sheet. You already have an 8 French sheet. You could have thrown it at 2.5 implant.
Jill just said was about the VTAC, and we thought that a lot of this LV injury or stunning was because of the incessant VT storm as well.
That's another indication for an implant.
That is an indication for an Impella, but what he's saying is it's kind of chicken or the egg. Is he VTAC because we have this backflow and we've got so much distension?
See, you
or
did
is
RODO,
he
right?
VTAC so
You did RODO, so there is a lot of like small vessel issue there. So the left ventricular myocardium is irritated because of all that extra thing. And how do we prevent that? We prevent by decreasing the wall
I'm playing devil's advocate, but
No, I'm just saying.
I was like, can we please get him?
You're actually this is a collegial, like we're all, I think that was the argument the ICU team was making as well, is that we need to unload the LV.
They're looking at this time.
It was really bad. So the first one that you saw, I mean, an initial presentation, that could just be pulmonary contusions from all the CPR, but he just kept getting worse. He was barely breathing.
There's probably an aspiration component during his downtime because there were thick secretions, and then he worsened with the picture that would fit like a pneumonitis picture as well.
Yeah, the first chest X-ray was
Pretty rough. Yeah, right below is.
The other option would have been, like Dr. Collins suggested, now you put in a left atrial cannula to decompress.
Yeah, because the VT may get worse. That's not a big challenge.
Yeah.
Put it in there as a section.
Yeah.
And
you
his
needed
VT,
decompression
VT
one
had
way or
started,
another.
his VT had started even before we started intervening and just kept going through, in spite of revascularization, in spite of atrial pacing, in spite of amio, in spite of lido, in spite of calcium mag electrolytes.
That's the thing, sometimes when EP guys do their VT ablations, we put an impeller so that at least you'll have flows and the ventricle is stable with persistent VT. So, I mean, I agree, it can cause VT, but it will be positional, basically.
So at this point, I think the cardiology team they wanted to go down the inotrope route. So Laura was started. It looks like the neuroplet started slowing too. So just needed more forward flow, I guess. Unfortunately, we don't have these images. Day one, yeah, day one.
I mean, the volume status in this situation.
So it's completely decompressed RV. It's just a almost completely underfilled RV plus the chugging on the ECMO circuit.
You see that with good ECMO flow, irrespective of
Because you're suctioning from
because
the
you're
right side.
suctioning out anyway, and RV is going to be small.
You can, yeah, but in the context he's chugging too in the ECMO, you can't get any sort of. You want a good ECMO flow to just take over. You couldn't without chugging. So, yeah, the vessel wall was just collapsing right down on the cannula, and because it's so underfilled.
Suppose you.
But his chattering stopped after he got the 6 units on the first day. So he was chattering a lot when he first got there. He got the 6 units, the chattering stopped. The RV was still totally flat. So you are right, like we're pulling out enough volume, we've got enough flow, that you're not going to be able to do like ultrasound.
No, but basically you are estimating just the way it is. When do you see that person is volume depleted and I need to give it? Just when you see the RV to be collapsed, which you expect anyway.
No, just the chattering.
No, yeah, the chattering and the inability to. So we put in the ECMO to take over, right? And we're unable to use this high-risk device at all because we couldn't get higher flows because they were continuing to chatter because they were volume down. So
are you saying that there's no objective way to measure the intravascular volume on the venous side when you have VA ECMO? Just you have to go by the chattering is subjective, right? I mean, you cannot quantify that. So there's no quantifiable way of measuring venous pressure when you have VA ECMO.
That's a good question.
You can still have a central line, hook it up to a.
Right, so that's your
you can, if it's like 15, 20, that's a problem. So it's usually the CVP is definitely higher. But if you see chugging and chattering, you have to give them fluids because there's nothing you can do. Unless you're seeing the RV so collapse, and if you've done an echocardiogram, probably IVC was probably smaller too. But we don't know that. For sure, when you see this, it's going to need more volume. You have to give it volume. There's nothing you can do. And there will be a dim in it. I mean, this is just day one. As I say, you're going to have an anasarca and everything by day 5. There's no way of assessing. And you may have to put him on CRT pretty soon. I'm surprised he's not on CRT.
Wait for day 2.
So you can tell when there's too much and you can tell when there's not enough, but everything in between is kind of cool.
Yeah, when the CVP is high, it's helpful, but when it's normal, it's not that helpful.
Yeah, exactly.
And did you guys did not think that this was all related to volume? And you thought that this was all related to LV dysfunction?
No, I think partly initially at least the thought was it was all volume, and that's why they were giving the transfusion.
And it's a mixed picture. It's volume.
Yeah, but the first few.
Well, when we are considering Nulinon, we are considering epinephrine.
Yeah, so
all these things are to help the LV.
The initial part of day 1, he actually had tremendous urine output. So that was a part of why we didn't think it was volume issue, is his urine output was, he peed out liters. So that was part of, there was a mixed picture, but that was one factor.
But at that time, he got 6 units of blood, you said, right?
He got 6 units of blood over the course of time.
And his urine output was better. His lactate was continuously trending down. I think there were 4 lactate levels, all of which were trending down. His ALT, ST were all trending down. So was his creatinine. So chemically, he seemed to be heading in the right direction, though the interplay of pressors and volume and ECMO numbers kind of were not very congruent.
So when you put somebody on 20 or 50 milligrams of epi,
Initially.
that causes profound vasoconstriction. So that itself is, I mean, it looks beautiful for a few hours. It's just a matter, it's just hanging right in the background. It's just a matter of bundling down. So there's no way this patient is going to do well, even though it looks better for a little while. It's just a matter of time. It's just this hours to minutes. It's just a matter of time. Plus the hypoxia is definitely not bad.
So just on a side note, like when we put people on pressors for any type of shock, we know that we're squeezing down on all the blood vessels, not just the big ones that are going to keep your brain circulating. We know we're about to shut down your kidneys, but that's a choice that we make because we can support your kidneys, but if we lose your brain or your heart, you're done. So we just lean on whatever organ systems we have. We know we're going to take their kidneys down.
So ended up getting a total of 12 pack units, red blood cells. And of course, they got the fibrinogen as well. So XA levels were a little low at that point, increased the heparin. So here, this is actually after the fibrin was given. R time, your CK heparin, so your R time with the heparin is slightly prolonged, but in this case, if the patient's not bleeding, I wouldn't really worry about it. And same with the functional fibrin assay as well. If the patient's not bleeding anymore, you can make an argument to transfuse or not to transfuse. It would be understandable. So that's just the same thing. So AT3 levels came back to 27. I think we kind of threw up our hands and said, screw it, we're going to bivalve, which is always the right call. Bivalve should be the standard for ECMO, I think, biased. It's much easier to work with and much easier to monitor. So at this point, the next tag, later in the day, we can see we're all over the map again. So our CK heparinase was way prolonged. So we have a coagulopathy brewed yet again. We have, again, the fibrin's way low as well. The fibrin function is way low.
Putting heparinase makes sense.
At this point, he's not.
This might have been drawn right before we switched.
Yeah, I don't know the timing of this tag. I think it was still either they were still on heparin at this point, or it just been turned off, and you're assessing the underlying if there's still heparin effect on there.
Okay.
Yeah. Let's see. So obviously, we're still pretty coagulopathic here, and fibrin's not working so good.
So blood, he is bleeding somewhere.
So he had small pericardial effusion on day 1, and we thought about doing pericardiocentesis to see it was small, and what was confounding was that the RV is collapsed, but it has been collapsed from day 1. So we were not sure whether that pericardial effusion is impacting the RV. We didn't think so. We checked. We did echo like every 2 hours, and the effusion stayed the same. So we decided not to do pericardiocentesis.
No, but 12 units.
I know. So in the right groin, it was losing. It was coagulopathic. Surprisingly, his arterial and venous cannula looked beautiful.
You would have put a fem stop or something, right? If it was bleeding that much.
Yeah, probably. Or just take the sheath out, because at that time we had not used it anyway. So sometimes the safety fails, right? It was
or you
left
put
as
an
a
8, 9 French or a 10 French sheath, and that may take care of it.
And that was another part of the thought process on Impella, that is already bleeding significantly, and then we are going to put another 14 French device. Are we going to make the bleeding worse? That was the discussion that we were having at the back end. I understand the sheath size and bleeding around it, but you are already putting a 14 French device in somebody who's fully coagulopathic. when we didn't know whether they really needed it from the cardiac perspective.
No, but the point is, like, if you are bleeding around the site, which is the only reason why you would continue to bleed from the sheet side, right? That's the only way you would bleed from the sheet side.
Okay.
So you would bleed with coagulopathic profile like him either way, right? Doesn't matter if it's a 6 French sheath
So
or
why is it not bleeding from the other side where you have big
we
sheets?
had perclosed it before putting the devices. I don't know if that cinched it well or I don't know.
He was bleeding from somewhere.
So you were bleeding from the venous side?
No, right
No,
femoral.
the inferior arterial side, but not the other side where you had big cannulas.
I mean, you have to remember, like you said,
Yeah,
a lot of things are happening, but we're still at day 2.
Yeah.
Yeah, so
Yeah.
time is stressed out here, right? But in real time, this was like
There's a lot going on.
lot going on. Still, it was day 1 that day.
Yeah. So at this point, with the bleeding had been fixed, our pressors are coming way down, and the milrinone was used to unload the left ventricle. At this point, the LV function was improving and actually rapidly improving. So the goal at this point was get him off of ECMO. There's just way too much going on here.
There was also failing. So at this point, it was going to be either we had to do a circuit change out or explant. And our timeline had been pushed up because we had also had the issues with loss of pulsatility that made circuit change out worrisome.
You knew the oxygenator was failing by the blood gases?
By how much we were having to deliver, how efficient it was working, but also by watching the blood clots in the oxygenator itself.
I think your delta pressure is on the oxygen going down too. So it's
Watching the efficiency, and then we just were watching it progress.
His LVEF on the morning of day 2 at 10 a.m. on milrinone looked like 65–70%.
So at this point, we're starting to turn him down, turn his flows down, test his heart out, how quickly we can get this thing out. This is probably at this point causing more problems. So they turned down to 1.5 liters for an hour. LV was doing good at that time. So the decision, I don't have the echoes, I'm sorry guys. And continue, like our creatinine is still amazing despite all this. The LFTs are better despite all this. That's pretty incredible. You guys did a great job managing that pump, by the way.
Pictures on the A cannula of the VA ECMO circuit?
Yeah.
Just like
Because we were expecting to explant it after the intervention.
Okay,
And
so
he just crashed, nosedive during it. We were forced to keep the ECMO. And since we had the perclose, we thought we'll try that.
So another issue, obviously, the patient's PO2 here is not optimal, to put it charitably. So obviously, we can do a better job of managing the differential circulations here. That was a talking point that we had that came up. Your post-oxy PO2 there is pretty good, actually 277, but delta pressures were up, so it's starting to. Now the LV was picking back up, and you mentioned before we were talking about. I kind of wanted to point out that you said that how's the coronaries getting perfused if you're totally dependent on ECMO. Kind of actually the real problem with it is not when you're dependent on ECMO flow. It's actually when you're having your own intrinsic circulation, right? Because you're pumping this blood into your coronaries in your brain. So that's really the problem right there. Is once you get that cardiopulmonary circulation back, you can run into that issue there if you're not very vigilant about it. Some changes were made, but by going up on the PEEP and trying to ameliorate that, but the fact that we let it get to 65 was definitely something we can do better. So decannulated, taken off milrinone, EF was low, and started to get all uric when the milrinone was stopped, so I had to go back on the milrinone. Started diuretics as well.
It was done in the cath lab. We had the 2 pre-closes. Actually, it went very well, surprisingly. Did not expect it to go that well. We were expecting more bleeding, especially
for this guy, right?
Yeah, exactly. Yeah. So, but the decannulation went very well.
How do you wean off the ECMO? Do you go down on the flow rate initially and
Yeah.
then decide to decannulate, or
Yeah, so you
how
wanna-
the patient is tolerating?
Yeah, so you want to basically, you want to see how their own heart can take over DO2, right? So is our heart strong enough to perfuse the body adequately? So you just ramp down the flows on the VA circuit. You don't want to go too low because you can cause clotting. I wouldn't go much below like 1.5, 2 liters per minute of flow. So you can, especially with this oxygenator, starting to go out. In case they fail, you're going to have a major issue. But yeah, so you just gradually wean the flow. And we don't do it, but some circuits actually have a bypass where you can have what happens is you clamp off to the patient and you have a circuit in between that just recirculates among ECMO and see how they tolerate that.
Without any issue, what's the weaning time? 4
So,
hours, 6 hours?
VA ECMO is great because VVA cases can last for months and months and months sometimes. But VA, within 72 hours, you're going to have a good idea of where this patient's headed.
Decide to wean to completely taking off the circuit. What's the time period? Like, let's say in a perfect situation.
I see. So I think one of the major things you have to be careful of is, I think the answer again to cop-out is it depends. What you don't want to do is you don't want to take your cannulas out after you've had a positive test and then something happens. Right? So we like to demonstrate a time period of stability, basically off ECMO on this trial or minimal ECMO flows, and then go back up so you don't clot, but then kind of watch them again and for a period of time. Depends on the situation. Sometimes anywhere between 6 to 24 hours, depending on the situation. You can do it. I mean, this guy, there's consideration to do it even faster because of all the issues he's got going on. But yeah, so it depends a bit, but about 24 hours. So,
failure, put him on ECMO, was really sick. We have had Swan-Ganz catheter at that time. We just monitor the PA sats. We monitor the RV function on echo. We've done TE on that. We're from 4 liters on a bigger VA, the real VA circuit. We've turned down to 3 liters, then 2.5, leave them for a day or two, especially if they're not doing well. And once we come like 2.5 or so, we just take them to the OR and take it out. It could be days, and then if it's an acute situation like this,
acute heart failure,
you could do
right?
it in,
Acute shock.
you could do it in 12 to 24 hours.
Yeah, this guy, we started weaning at 10 o'clock and he was explanted at 2 o'clock in the afternoon.
Plus his EF was it was only 60%.
Really, his was more of a trial to see if the native heart was going to be able to withstand that workload, or if not, then we were going to have to escalate to like an Impella or something to support things while then we would change out the circuit.
Yeah, so that's a good point that Dan mentioned, that when we started the wean, it was a diagnostic wean as well, because we finally decided that if he doesn't tolerate the wean, then he's gonna get an Impella.
It's just the big picture on this one. His EF was 40% going in. So it was never like one of those big
And you can see the echo still image, the LV cavity is
It's
small.
not big.
The question
yeah.
is what exactly
And the wall thickness is
Stun might
usually-
come from all the roto and the micro
VT storm, to be honest,
Yeah.
my personal
And then
opinion on
VT and
this is
VT
all
too.
VT storm, and the coronary artery disease was bystander.
Yeah, and the VT, yeah.
Because of course, hindsight is always great to go back and just reassess it. So I'm not sure if VA Impella actually made things worse with the hypoxia and everything. His EF was never terribly bad. But once you control the VTAC and fit, maybe he has got
I think it was stunned
better,
myocardium,
just
to
because
be
it's so
honest.
hard to sort of see so quick improvement. Once you start coming down on the flows,
Yeah.
your oxygenation, quote unquote, improved.
yeah.
Is that true, or is it?
I think so. I wasn't there for the week.
Was the oxygenation improved once you started turning down on the flows on the ECMO circuit?
Like the patient they improved somewhat, but we were still there was a lot of ventilator support.
PP went up to 12.
Yeah, and we had gone from a volume control to a pressure control setting to try and help our ventilator issues. But we were still on a lot of ventilator support, but we were able to successfully do it. The kind of retrospect is the ECPella question. And the limiting factor here was that coming out of the cath lab, the EF wasn't that bad, but by the time you got up to ICU, it was bad. And then it was a question of, well, we didn't know if he was going to recover soon from just the VTAC storm, or if it was going to be a little bit longer. And that's where the question, do the Impella at the kind of the initial time versus when we look at it retrospectively, it's pretty. I think a lot of people will say, oh yeah, just do it. But there were kind of each individual situation that made the decision to do it or not more complicated.
Typically, when someone has low EF and they come in for a VT storm, we put an Impella in and let them stay in VT for 2 hours or 3 hours that they are doing the VT ablation. Once the VT ablation is done, we leave the Impella overnight, and the next day we take it out. Pretty much without so someone who's on VT storm for like 2 hours, you usually leave it for a day.
Yeah.
And obviously we check everything, but
So
that is a typical time for recovery.
At the ICU side, we were asking for an Impella largely because we were running into logistical issues with the circuit and trying to prevent the cardiac standstill, everything like that, that was very concerning. From a cardiology standpoint, we didn't express it correctly in the beginning. We didn't articulate it that we were having other issues that we were managing, not just awaiting return of native heart function. And so from Duvall's standpoint, he thought no, I think the native heart will return quickly. And we just didn't express it in a way that we don't, regardless of the native heart, when that returns, we're having major management issues that it would help us out with.
Yeah, that's a logistical, technical perspective that we did not have, right? I mean, we were purely looking from a cardiac standpoint, right? His creatinine, his lactate, his LFTs, everything is trending better. His EF looks better. I think it's a stud myocardium from VT storm for 12 hours. So we were focused on that side, and they're like, okay, why should we put an Impella when he's getting better? That was my thought process, our thought process.
That was day one. I mean, like I said, things have been happening.
Yeah,
so
and then
quickly. I'm
to
sure
Dan's
day one. The
But
next
to
day,
Dan's
if
point-
things were getting like you have still 20%,
Yeah, so
probably
we
you
talked
want to
that
have this
if
discussion
if
with
he
the
doesn't
Impella.
tolerate the V, you will do the Impella. But to Dan's point, there are factors outside the cardiac perspective that sometimes warrants an Impella, like with his episodes of cardiac standstill and the oxygenator not working, having to change the circuit with the downtime of possibly 5 to 10 minutes to change the circuit. He may not tolerate that, and for that to have an Impella as a backup, So those non-cardiac perspectives of why an ECMO patient might need Impella, that was refreshing for us.
And one other area that we get very concerned about is the neurologic function. And this patient unfortunately did sustain a small cerebellar stroke. And as to exactly at what point that might have happened or what factors contributed, can't say completely, but when we have a cardiac standstill or loss of pulsatility, it would be, from our having an Impella as like a floor to fall back on is very, very beneficial, especially if we have to do circuit changes in the midst of all the arrhythmias and everything like that.
Also, your patient oxygen was quite low for a long time.
Yeah, so this was, in my opinion, this case, thankfully the patient had a favorable outcome, and to my knowledge is doing quite well. But I think that we dodged bullets, multiple. He dodged bullets, and that's why it's such a good case to review going forward of how can we smooth out this process a little bit more to try and have a better process going forward for future cases.
I think, with him, it was like benefits versus risks, mostly like vascular. I think it was like vascular bleeding versus the hemodynamic support. That was like in the balance. Again, this is retrospect. Waiting probably in this case 1 day, like 24 hours, and see what's gonna happen, what's not wrong. By day one, if like day one, like the echo is still 20% and you still have loss of pulsatility, definitely would have been Impella. If that patient, that's my personal, if that patient didn't have the bleeding issue and loss of volume, all that stuff, probably you go for Impella from the get-go.
Again, it was a roller coaster. So myself and Marston were in that room. I mean, I was on kind of for the ECMO part, but Marston was the primary on it. And between the two of us, in a 12-hour shift, he spent probably 9 or 10 hours in the room, and I spent 6 or 7 just at bedside because it was just back and forth. And that's also why it was never clear, oh, we need an impella, or no, we don't, or that yep is this, because it really was back and forth.
So just the last few things. So we will say, this is what we did really well, improvements, and what we did really well this year. Here's how we can improve. So, we picked up on our TEG issues, picked up on our mixing cloud issues, ventilator and ECMO adjustments, respectively. Kind of address those. And then kind of also, again, the need to kind of get the shock protocol off the ground and really get as involved facility as possible. So we talked about ECPella and why do we vent the LV? I think we understand that now. LV dilation, reduced LVEP. We saw from the Harvey loops today why Impella can be useful in that respect. Poor LV ejection cause LV thrombus. The question becomes, is cerebellar infarct, could that have been related to these periods of no pulsatility? We'll never know. Yeah, so again, we have here, so we can see why it shifts it all the way to the left there to vent the LV. We talk about the reasons why we want to vent the LV and when we do it. And we talked about some studies too. So we're always trying to incorporate evidence-based medicine. And we showed a couple of, again, the trouble with ECMO is that there's a lot of, there are studies out there, but it's really hard to do a randomized controlled trial for ECMO because there's such few, there's such few cases that it's really hard to get a large-scale study. Even the Caesar trial, one of the biggest ones, the landmark ones, has actually got quite a few issues with it too. But we talked about this and it showed really good outcomes with ECPella. And these are all retrospective analyses as well. So you have to take that kind of with a grain of salt as well, or at least keep that into perspective. So we talked about comparing intra-aortic balloon pumps. I'm rushing through this because we're pretty much out of time. So we compared IABPs, which appear to be in these to be inferior to Impella or ECPella. So I just wanted to show you guys that we like to include all these, and there's actually reduced mortality with ECPella versus no Impella. And these are some of the data here that we put. ECMella, I don't know why, but in Europe they call it ECMella. I have no idea why they chose a different letter. ECMella. So obviously there's problems with it too. So we talked about it in our case, and that was pretty much it. So I don't want to take up too much of your guys' time.
Discharged on I think day 10 or 12 on room air and had no neurodeficits from that small cerebellar stroke.
Thank you very much. It has been amazing 1.5 days. It seems that we have covered so much. Some of the concepts have just touched our inner core of the brain, and some of them are getting brushed up. But I think cannot thank enough for our ICU colleagues. Your presence your presence and your enthusiasm and support makes all the difference. And you brought some very dedicated nursing staff as well along with that. That makes a big difference. How we work together and we see those familiar faces again and again in the ICU. So it's a collaborative effort, and Dr. Kalia, who very graciously spent 2 days with us, got to know him a little bit, how he thinks, and we're really, really grateful to you for being here. Dr. Lemon, who was here earlier, and again, she was with us. So it just shows that all of us in this room have lost patients. Some of the patients we have lost because of their disease. Some of the patients we have lost because of poor judgments. And some of them we have lost because of our mistakes, clearly. And we take ownership, and we just pray for our patients who we lost, and we take this learning to the next level so we can prevent further losses. I think that's the whole thrust of education and trying to do better than what we can. I'll just like to say thanks to our exhibitors who were here earlier and they supported us for Patrick with Boehringer and Livanova, Zuby and Joel, and Biomed Narita and Stacy King and George's office, Premier Cardiology, and my office, who were really, working in the background, especially Marie and his sister and so many others, although it's a small endeavor, but trust me, it takes a lot of effort and a lot of planning. Again, but the real people who were here, which made the difference was your presence. And we have VAS, who we are very proud of the fact that we have known them for more than 20 years. Brian, who is here, and Kris Woolley, who was not here but has been our main supporter and did an amazing job. Hopefully, we'll be able to get these videos on the website, and some of the concept we can get it clarified when we have time. And from this conference, I hope and pray that we see you next year. George hasn't really committed, but I'm going to push him that we do it next year as well. And wish to see you all again. Thank you so much. Thank you very much.